Order. We'll call our meeting to order now. This is the Standing Committee of Public Accounts. My name's Nolan Young. I'm the chair and the vice chair of this committee. I'll just remind members before we start, they can check their phones, put them on silent. If there's an emergency here, we will exit out through the doors to Granville Street and gather at Grand Parade. And I'm going to ask the members to introduce themselves, starting with our newest member to Public Accounts, and welcome.
Good morning, everyone. Marco McLeod, Victor West.
Good morning and welcome, everyone. Tom Taggart, Colchester North.
Good morning. Johnny McDonald, MLA for Hants East.
Good morning. Welcome, everyone. Thank you for being here. Melissa Sheehy-Richard, I'm the MLA in Hants West.
Good morning, everyone. Susan LeBlanc, MLA for Dartmouth North.
Hi, everyone. Lisa Lachance, MLA, Halifax, Citadel, Sable Island.
Good morning, everybody. I'm Braden Clark, MLA for Bedford South.
Good morning. My name is Kelly Regan, and I'm the MLA for Bedford Basin.
Just to note that we have officials from the Auditor General's office here in attendance, and also in attendance are officials from Legislative Council office and Legislative Committee's office. On today's agenda, we'll have officials from the Department of Health and Wellness, Nova Scotia Health, and Emergency Medical Care Incorporated with respect to a progress update on actions to improve emergency care. And I'll ask the witnesses to introduce themselves. Perhaps I'll start on my left.
Good morning, everyone.
Mr. Crossman.
Good morning, everyone. My name is Matthew Crossman, President and Chief Operating Officer for EMC.
Hi, everyone. Nicole Boutilier. I'm the Executive Vice President for Clinical Operations and Medicine at Nova Scotia Health.
Good morning. My name is Karen Oldfield, and I'm the Interim President and CEO at Nova Scotia Health.
Good morning. I'm Jeff Fraser, Senior Executive Director for EHS. We operate the Office of the Regulator.
Good morning. I'm Dana MacKenzie, the Deputy Minister for the Department of Health and Wellness.
Good morning. Colin Stevenson. I'm the Chief of System Integration with the Department of Health and Wellness.
Thank you. Welcome. We'll invite opening remarks, perhaps, and we'll start with Deputy MacKenzie.
Thank you.
Deputy MacKenzie.
Thank you very much. Thank you for the opportunity this morning. We have made great progress in acting on what was outlined in the Emergency Department Improvement Plan. We have brought in patient advocates, waiting room care providers, flow and offload teams, and virtual care in EDs. Could you, I'm sorry, I'm gonna start again here. I'm in my wrong notes. I'll have to reorient myself here. Just a moment. Our healthcare, let me begin again. Thank you for your patience. Our healthcare system is complex. It's interconnected. There are barriers that need to be overcome, and we are overcoming them. Despite the challenges, there are opportunities. Each opportunity, solution, innovation has one thing in common. The patient is always at the center of what we do. We've made significant progress to stabilize healthcare for Nova Scotians by creating and enhancing more options for primary, urgent, and emergency care closer to home. Mobile primary care clinics, after-hours clinics, urgent care centers, urgent treatment centers, community pharmacy primary care clinics, 811, Virtual Care Nova Scotia, Your Health NS. These are just some examples. These services support what we're here to talk about today: improve emergency care in the province. These services are aimed to help people get the care they need in a more appropriate setting so they don't need to go to an emergency department. We've made direct investments in emergency care by way of new infrastructure, digital healthcare, and people. We are modernizing or replacing outdated facilities to meet our current and future needs, like a new emergency department in Yarmouth, or the redevelopment of the QE2. We are helping patients in hospital to return to where they call home sooner by helping them mobilize sooner, using data and health information to fix problems in real time. and expanding evening and weekend access to interprofessional teams. In doing so, we are reducing wait times, ambulance offload times, overcrowding, and other system pressures often faced in our emergency care system. For people who must visit an emergency department, we've made changes there too. 13 emergency departments have added licensed practical nurses and patient advocates. They provide support, comfort, and information to those who are waiting. More than 100 team members are currently working in this role. 7 emergency departments have emergency physicians care for patients in rapid assessment zones. We've integrated virtual care in 2 emergency departments and 15 urgent treatment centers to offer some patients the opportunity to see a physician virtually. This helps get them the care they need sooner and allows physicians to see more in-person emergency and urgent cases. We've invested in people like paramedics and others who respond to emergencies because care begins the moment you call 911. Improvements like increased staffing at the Medical Communications Center, recruiting 30 paramedics from Australia who will start work this year, enhancing the role of some advanced care paramedics to work as single paramedic response units that respond to lower acuity calls and discharge patients at the scene. Introducing a new role, emergency medical responders, who are working alongside paramedics providing basic care and expanding the number of teams in communities that can respond to an emergency. Creating more opportunities for new and existing paramedics to stay and work in Nova Scotia with tuition rebate programs. And of course, strengthening our fleet of ambulances, patient transfer units, medical transport service, and air ambulance service. As I mentioned at the outside of my remarks, our healthcare system is interconnected. That is why we will continue to take a system-wide, patient-centered approach to improve primary, urgent, and emergency care for Nova Scotians. Thank you again for the opportunity to provide an update on our progress to date. Thank you, Mr. Chair.
Ms. Oldfield, I think you had some opening remarks as well, Ms. Oldfield.
I do. Thank you. Today with my colleague, Dr. Nicole Boutilier, we'd like to highlight our ongoing efforts to improve emergency care across Nova Scotia. In February of this year, Nova Scotia Health launched a system accountability framework to provide and improve timely access and care to queue management strategies and surge contingency plans. This initiative alone has saved nearly 7,000 hours of ambulance time, and that means that EHS can respond to 911 calls much faster. The longest offload times have dropped by 110 minutes, and the number of ambulances waiting beyond target times has decreased by about 50%. For example, the QE2 Halifax Infirmary is down 128 minutes. South Shore Regional down by 122, and Cape Breton Regional down by 92. In emergency departments, the time to transfer patients to inpatient care has been reduced by 21 hours, and the length of stay for admitted patients in the ED has decreased by 17 hours. The Care Coordination Centre, or C3, is a key resource enhancing patient flow across the entire province. By providing real-time data on bed availability and care needs, C3 has streamlined a previously cumbersome and resource-intensive process. Now we know our system-wide bed capacity at any given time, and that makes patient admissions simpler and faster. There are several other new initiatives which support a faster, more efficient, and improved patient experience. Initiatives like the Rapid Assessment Zone. Now, in 6 emergency departments across the province, rapid assessment zones treat patients with mid to high acuity conditions who can remain ambulatory. These areas are designed to see a higher volume of patients that do not require a bed for the whole visit and can use a chair or a recliner to wait for x-rays, tests, or even receive an IV. They use 2 to 3 bed spaces to see people in private and then move them to chairs and recliners. This allows for higher volume, and it saves dedicated beds and stretchers for patients who require dedicated bed space, like our frail, elderly population. This model handles up to 30% of emergency department patient visits. It reduces wait times and decreases the number of patients leaving without being seen. And since the start of the fiscal year, rapid assessment zones have managed over 6,000 visits. New roles in the emergency department are also making direct positive improvements in patient care. Roles like waiting room providers, patient advocates, physician assistants, nurse practitioners, and others are significantly decreasing the time that patients spend in the department and improving their care experience. So a waiting room provider checks vital signs, inquires about pain levels, and escalates any changes in the patient's condition to the physician or clinical need nurse, reducing the patient's stress level and supporting them to get the care they need faster. Patient advocates make the experience of waiting for care less overwhelming by providing additional comfort to the patient during their wait, whether in bringing a warm blanket, food, whatever will make the patient more comfortable. 7 regional sites have introduced physician flow leads, a dedicated physician role to accelerate patient care and reduce delays in diagnostics and treatment. Part of providing emergency care is providing Nova Scotians with more access to primary and urgent care and knowing what level of care fits their needs and how to access it. Since its launch this time last year, Your Health NS app has been downloaded more than 400,000 times. Our website and the Your Health NS app share approximate wait times for 14 different emergency departments in the province, and these are key resources in navigating care. Virtual Care NS and pharmacies also play a significant role in diverting unnecessary visits to the emergency department. Never before have Nova Scotians had access to more effective tools, resources, and sources of care. Despite significant challenges like high occupancy, high acuity, and high demand in emergency departments, we have made progress in reducing ambulance offload times and improved many facets of emergency care. And we are committed to finding new and better ways of providing care and adopting those innovative approaches to meet the demand. Before I conclude, I would like to thank our healthcare providers and our staff across the system for their continued support and dedication to emergency health care in Nova Scotia. Thank you.
And Mr. Crossman, I think you had some as well. Mr. Crossman.
Yes, thank you. Good morning, everyone. On behalf of Emergency Medical Care Incorporated, I wanted to thank the committee and its members for inviting us here today to discuss the progress and future of emergency health services in Nova Scotia. First, I'd like to extend our heartfelt gratitude to our employees and our teams. Their unwavering dedication, working day and night in difficult conditions, ensures that not only our communities receive the care for them when they're needed, but it also goes above their duties. It means they're caring for their friends, their families, and members within the community. For them, it's personal. Last year, we responded to almost 200,000 calls. It was one of our busiest years yet we've made some significant improvements in our system. I'd also like to take a moment to honor not only just frontline paramedics and health staff, but all those first responders. Today's date is a constant reminder, being September 11th, of the sacrifice and ultimate sacrifice some of those folks make, so I wanted to thank them and their families. Our partnership with Nova Scotia Health and the Emergency Health Services team has never been stronger. Together, we are transforming emergency care as is delivered not only in ground, air, but also through digital innovations. For instance, we've added a new air medical transport system, which has been able to enhance the patient experience, transporting patients from Yarmouth and Sydney and different areas across the province, bringing them better care, faster care to the center. But it's also added 11,500 hours back to the emergency health service system, where we've been able to respond to those communities. As Ms. Oldfield had mentioned, offload delays are actively being addressed with our partner. We're working closely with Nova Scotia Health, and we're looking to implement strategies to reduce these delays and improve overall patient experience even further. These collaborative efforts are essential for us to make differences not only in the emergency health services side, but all patient care across Nova Scotia. Our workforce remains our most valuable asset. With over 1,500 employees, 900 being paramedics, recruitment and retention are our key priorities. We've seen, since I've joined the organization in January, a 41% increase in the recruitment of paramedics, both locally and internationally. And we've also looked at different initiatives and how to increase those numbers. I'm proud to say that for the first time, our vacancies are down to about 67 across the entire province. It's one thing to be able to get employees, but it's another to also make sure we maintain them. And I'm proud to say that since January, we've had a 51% reduction in the amount of attrition for paramedics across the province. New roles are being introduced as emergency health services have just announced with the EMR program, and we're very excited. Not only is this a new tool in our tool belt to be able to utilize, but it's also a stepping stone where individuals can enter a career and progress throughout into paramedics and other types of roles. We're also working with the union. In December of 2023, the Union of Operating Engineers, we were able to reach one of the best agreements that we've been able to make. It's made an increase in pay for our employees. It's had a huge impact on the employee morale, and it's allowed for us to create more permanent and casual positions. This new role has allowed us to stay competitive not only here in Atlantic Canada, but across the country. We're committed to supporting our employees and improving health and safety through proactive improvements. We've added a lot of mental health supports, and we're going to continue to increase those efforts. I'm proud to say that we're looking to add in a psychologist through our Medivy organization that's going to be able to provide direct support to our frontline staff. This is important so that we can get them back out in the communities after they experience very difficult situations and make sure that they have the support that they need. As a paramedic myself, I find it crucial to stay connected to the frontline staff. I try and get out as much as I can, and I think this allows me to see how things are actually operating in the front lines and be able to make adjustments through our senior teams as the system evolves and changes. Looking ahead, we're committed to addressing several challenges, including human resources shortages, increased call volumes, and offload delays, just to name a few. Our system innovation, such as direct transfer to care, has allowed us to put units back out onto the road. About 13% of all calls now are patients are being transferred to the waiting room when we arrive at a facility. And with some of our other programs, like our clinical teams and our communication center, care starts the second that somebody answers the phone. We're able to utilize the physicians, nurses, and paramedics in that center. And I'm proud to say about a third of our calls result in non-transport, which allows us to be able to get to people quicker. We've seen a 36% reduction in response time across the province, not only just urban but rural, and we're continuing to look at innovative ways to be able to do more with our resources. And we're committed to the ongoing collaboration, innovation, and responsiveness to meeting the needs of Nova Scotians. This includes continual feedback from our front line. We've created employee advisory committees. We're looking at all kinds of different ways to get feedback from the frontline staff and make sure that they're involved in the decision making. In conclusion, I just wanted to say thank you for the opportunity to be here today. I wanted Nova Scotians to know that our team is continuing to push forward and strengthen the work environment to ensure that not only our employees are supported, but all of the individuals in the communities are as well. Thank you.
Perfect. Okay, just quickly a housekeeping item. Originally, the clerk had recommended that we stop at 10:35 because to do with the committee business. I'll bump that up 5 minutes, 10:40, just because we started 5 minutes late. And without further ado, this committee is 20-20-20. If you're in the middle of an answer and I cut you off, I don't make the rules. I just follow them. So my apologies. We'll start with our Liberal colleagues. I recognize MLA Clark.
Thank you, Mr. Chair, and thank you, everybody, for being here this morning. Deputy MacKenzie, you touched on a word in your opening comments that I wanted to hone in on a bit, and that's the fact that the healthcare system is interconnected. And I wanted to start by talking about the interplay between primary care and emergency care. So As we all know, the number of people without a family doctor in Nova Scotia has gone up tremendously over the last few years. It's up over 160,000 people now, just over 16% of the population of the province, and that growth is not distributed equally either. So, for example, in the area I represent, that number has gone up between 3 and 4 times over the last 3 years. And talking to people over the summertime, knocking on doors, it remains, I would say, the #1 issue for a lot of people. And a lot of the programs and policies that have been put in place, I see, and I think a lot of people would see them as supplements to attachment to primary care, not substitutes. And I think that's a distinction that I think most people would agree with. They want as a foundational piece, fundamental piece to their health care, to have a family doctor. So, Deputy MacKenzie, I'll direct this to you. If you want to direct it to others as well, feel free. But I just wanted to start and say, what impact does that massive increase in people without a family doctor have on the emergency care system?
Deputy MacKenzie.
Thank you for the question, and you're absolutely correct. The system is interconnected, and your question highlights the impact of the NFPR, or the unattached list, on the emergency care system. So with respect to a complete answer, I'm going to signal that I'll eventually ask Chief Colin Stevenson and Dr. Boutilier to weigh in on efforts undertaken to deal with some of the ED impacts and some of the things we're seeing there. But in terms of the interconnectedness, I think that one of the important things is to realize that the increased access points, there is real progress being shown on people being accessing care at different points in the system through virtual care. The NFPR list is entitled to, people on it, to unlimited virtual care, and there's been a great deal of uptake with respect to that service, and many Nova Scotians are availing of that particular option. And I think the number, and I'll stand to be corrected by my colleagues, of the addition of 70,000 additional appointments each month in the system, we are seeing that lower acuity patients are not showing up in the EDs as a result of those access points being created. And I'll defer to my colleague Colin Stevenson and Dr. Boutilier to elaborate on that if they feel that would be helpful. So in terms of the impact, because of the challenges associated with access to care in terms of the NFPR, our efforts remain relentless on things like trying to recruit and ensure that we're doing all of those things from a health human resource perspective that we can to compete globally with respect to ensuring that we continue to be relentless in our commitment to improving access to care for Nova Scotians. So with that, I will actually hand the microphone, if it's okay with the chair, to Mr. Stevenson, our chief, and to Dr. Boutilier.
Mr. Stevenson.
Thank you. And I can't quite make eye contact with Nicole, so I'll talk a little bit from a strategy perspective, and then she may want to talk about some of the specifics if it is helpful for the answer. But as the deputy has indicated, really, like the intention around emergency care as one piece of it really is kind of tied to all the pieces of work that we're doing within the health strategic plan. So for Action from Health, and the ability to kind of create access to care, both from our primary care, but also sort of access overall, if we think about it holistically. So I'm sure through the course of today, we'll get an opportunity to talk about improvements in inpatient care, as well as improvements in sort of pre-hospital care through the EHS, the MCI side. But the question specific to primary care and the impact on emergency, really the opportunity that we have had really is not just for those that are unattached, but for all Nova Scotians to understand that there's different places and ways to access care when you need it. And historically, I think everybody went to an emergency department because the emergency department is what they've known, and we're seeing more and more people, more uptake to things such as urgent care, to other alternative primary care access points, such as virtual care, as talked about, or mobile clinics, or primary care clinics for those that are attached. as the pharmacy uptake has grown, we've seen, and we see a lot of that with folks, higher utilization of, say, the pharmacy walk-in clinics for folks who are unattached. We are seeing that sort of coinciding reduction in the use of emergency departments to the point where the number of emergency departments that are being utilized by individuals who are unattached is starting to approach the same as what it is for somebody who's attached. So it's starting to normalize. We're seeing over time it's kind of moving in that direction. So that unattached population is starting to have a reduced amount of impact on the emergency departments.
Dr. Boutilier?
Thank you. Great start to the question about talking about interconnectedness, because I think the most important thing that we could highlight today, the system accountability approach that we're taking to improve care, is across the system. You don't fix one section without fixing everything. So our steady incremental progress over all the ways of care is really what we need to highlight. As we make improvements in the emergency system, as we make improvements in the inpatient hospital zone, as we make improvements in the community, all of those things work together to get us to a better place. As Colin just mentioned, we have, the lower acuity options, the triage levels 4 to 5. You've heard us speak about that before. They've been decreasing in our emergency rooms as there's more access in the community for people to find other ways. We also know that emergency rooms are becoming increasingly complex. More and more population, more and more aging of the population, we get more and more complexity. When we look at primary care, we have really had a historic master agreement where we now have for physicians, we now have an agreement where we are being lauded in Canada from the CCFP to actually bring people here. And we've seen...
Mr. Clark signaling that he'd like to ask another question. Mr. Clark.
Thank you, Mr. Chairman. I apologize, Dr. Boutilier. I don't mean to interrupt you. We have 20 minutes, and I'd like to get to as much as I could. So thank you. Thank you. I appreciate that. I also wanted to ask a bit about accountability and some targets in terms of, the metrics of how we're doing. So the province's goal is 90% of ambulance offloads in 30 minutes or less. What are we actually achieving on that metric at this point in time? And I'm not sure precisely who I should direct that to, but Mr. Fraser, maybe? Or
we'll start with Mr. Fraser. Mr. Fraser, if you want to pass it off, you can. Mr. Fraser.
Yeah, I'll pass it off to the Health Authority.
Okay.
Dr. Boutilier. Oh, that will come on for you. Yeah.
Okay.
Dr.
Is it on
Boutilier.
now? Okay. So we, as I spoke to a few minutes ago, this incremental progress, so we've given teams and targets of 10% reduction every month, month over month, month over month. So we've seen a 50% reduction at the 90th percentile for all offloads, returning 7,000 hours to the community for EHS. As we do that, it's a very systematic approach. We're not just looking at that one target. We're looking at multiple targets right across the system so that all the teams are working together towards the same goal. And, as we challenge the teams, on top of this, we've had this increase in complexity. We have 400 more people being admitted to our hospitals every year. And we also have just growing people that are coming in needing different levels of services. So on top of that, the teams have been able to get together and do that. We've had workshops. They have toolkits. We've added many things to their, like the RAS. We heard the talk about the Rapid Assessment Zone and how we can look at different acuity levels differently in real time in the emergency room. We've added float teams. We've added care providers. We've added different professions to the emergency room, nurse practitioners, physician assistant.
Mr. Clark.
Thank you, Mr. Chair. And again, apologies, Dr. Boutilier. I know it's a complicated issue, so I'm not trying to cut you off, but I want to make sure I understand the metric here because you started talking about that at the beginning there. So the goal is 90% offload in under 30 minutes, and I know that your goal is 10% improvement month over month, but right now today, what percentage of offloads are happening in 30 minutes or less? Do we have that?
Dr.
Yeah.
Yeah, Dr. Boutilier.
Yes. So over 30% now are happening at that 30-minute mark. And I will say that the 30-minute mark is something there's not a national standard or anything. Some places are 60 minutes, some places are 45 minutes. There's nothing that's a national standard around that. We started with that, and what we've seen is we've decreased 110 minutes all over the place on that particular metric at this point in time. It started in February. It's been the first time Nova Scotia's taken a systematic approach. This problem is not new. It's been happening since the early 2000s. And we actually are making real-time progress.
Mr. Clark.
Thank you, Mr. Chair. And moving to ambulance response times, kind of a similar vein of questioning here. So the goal is to have 80% of ambulance responses within the target. What is the percentage right now that are within the target in terms of ambulance response times from call to arriving on scene?
Mr. Crossman. Oh, Dr. Boot. Okay, Mr. Crossman.
Thank you for the question. We really appreciate it. So our goal is to improve response times all across the province. As I mentioned before, we've had a significant improvement since January. We've reduced the overall response times from 36 minutes to 18 minutes across the province in emergency settings. And we're continuing to push on that metric. So we're working really closely with our partners at the Department of Health. We've implemented a bunch of different initiatives to kind of address this. So as I mentioned, a third of our calls are not being transported now. They're being cared for in the community because they're not necessarily an emergency situation that needs to go to the hospital. So we're being able to treat those patients better in their homes and in the communities. We're also, as Dr. Boutilier mentioned, when we look at offloads, we know whatever we can do to help decant the hospitals is another big initiative. So we've implemented a program where we're doing supportive discharge through our paramedics and also through 811. So patients who are in the hospital, we're trying to get them out of the hospital quicker and support them better at home. And all this has impacts on our response times.
Mr. Clark.
Thank you, Mr. Crossman. Thank you, Mr. Chair. As we all know, there was an AG's report last year about ground ambulance services, which had within it 14 recommendations for improvements going forward. And I'm wondering, at this point in time, how many of those recommendations, how many of the 14 are complete, and what is the timeline to complete the remainder if there are some left over?
I see Mr. Fraser nodding. Mr. Fraser.
Thanks for the question. So that report obviously was tabled at the start of October last year. There were 14 recommendations. We have 8 of 14 complete. 2 will be done in the next 30 days, and the remaining 4 we'll work on throughout the rest of the year with the goal of achieving this as the AG has outlined within the 2-year period.
Mr. Clark.
Thank you, Mr. Chair. So the end point to have all 14 complete, Mr. Fraser, would be October 2025. Is that right?
Mr. Fraser.
That is correct. Yep.
Mr. Clark.
Thank you. Appreciate that. So one other question on targets, wait time targets, and that's with regards to emergency department wait times. So the goal, again, is in this case 90% within the target. Where are we at on that particular metric in terms of how long people are actually waiting in the ER rooms?
No, Dr. Boutilier.
So we have, Matt could probably give us the exact number right now for that. We tend to look at it a little bit different way. When we do time to triage, and that is like our actual measurement of when people start to receive care. If we're accepting them from emergency, they're already receiving care. So we measure time to triage as that. Because when you come into the emergency room, you are immediately, as you get to the triage, starting your care path.
Mr. Clark.
Thank you. And Dr. Boutilier, do we know what is the time to triage, I guess, right now, and how would that compare to the last number of years as well. And I see someone back there.
Yeah.
Okay, so do we not have that at hand? Just want to make sure.
Dr. Boutilier.
Matt Clark, the Chief Data Officer, is behind me, and he's getting the number for you.
Mr. Clark, do you want to continue while he's...
Yeah.
Mr. Clark.
Thank you, Mr. Chair, and thank you for whenever that comes. I appreciate it. Another issue is surgical volumes as well. So we know that population growth in Nova Scotia over the last 3-4 years has been, essentially off the charts compared to what we've been used to for the previous number of decades. And how do surgical volumes and the ability in some cases to keep up with that demand, how does that also impact emergency care, to our earlier discussion of the interconnectedness of the system in general? Perhaps that's for NS Health, I'm not sure.
Okay, Mr. Stevenson.
Yeah, happy to start, and Nicole may want to kind of fill in. So I won't be able to kind of give you the exact numbers associated with surgical volumes. Don't have that information with me today, but we have been seeing a reduction in the wait list associated with surgeries, and that really is kind of again tied to the strategy around focusing on increased hours of operation from the ORs themselves. And really ensuring that we have protected inpatient capacity associated with beds, which is a key component to it, and utilization of a different sort of sites and locations. So expansion of opportunities for ophthalmology and increased use for the East Coast Surgical Center within Dartmouth have been the big strategies associated with that in particular. I think the big piece as it relates from surgery to inpatient capacity to EDs, if we're thinking about that from the connectivity, really would be the increased focus around how we support patients to move through the system so that they're not staying in beds as long as they previously were, so reducing the length of stay for inpatient, which actually has a spin-off on both sides. It allows for protected beds and increasing surgery, and it allows for patients to actually have a more timely move from the emergency department into inpatient capacity. And there would be a number of strategies which can actually be spoken about when it relates to access and flow, in the sense of increasing the care teams on weekends, the mobilization team, the C3 are all examples of key initiatives which would be increasing and supporting the movement of patients within a hospital, which actually creates the capacity within the emergency department.
My apologies. MLA Clark with approximately 2 minutes. MLA Clark.
Thank you, Mr. Chair. So 2 minutes, I'll get to this question hopefully here. So last year, as we know, the AG report came out. The department at that time indicated that there would be the possibility of fines for EMC if they did not meet targets with regards to ambulance response times. And I'd like to ask Deputy MacKenzie, has the Department of Health and Wellness had to issue any fines against EMC in that regard? And if not, why not?
Deputy MacKenzie.
Thank you for the question. I'm going to confer with Mr. Fraser for a moment. My recollection is that we have not, but I just want to double check on that quickly.
Deputy MacKenzie.
Thank you. That particular item came up in the AG report as one of the items, so Mr. Fraser is going to actually take the answer here.
Mr. Fraser.
Thanks for the question. So that's one of the remaining items that we are working through. So we've initiated the change request process with EMCI. We're in the process of negotiating in around what penalties will be involved within the system. That's one of the ones we're hoping to achieve within the next month.
MLA Clark.
Thank you very much. I appreciate that. So if any fines were to be issued, it would not be at least until a month or so from now when that system is in place. Is that right?
Mr. Fraser.
That's correct.
Okay.
MLA Clark.
Thank you, Mr. Chair. Am I out of time, more or less?
You have a whopping 20 seconds.
Okay. Well, I'll thank everybody. We have
Dr. Boutilier.
Dr. Boutilier, yeah.
So our goal is to have it 90th percentile for the time to the physician, and it's currently at 4.2, down from 8 hours.
Impeccable timing. I'll recognize our MLA LeBlanc with the NDP for their 20 minutes. MLA LeBlanc.
Thank you very much, Mr. Chair. Thanks for to everyone for being here. Can someone tell me how many nurse practitioners are now working in ERs across the province?
Deputy MacKenzie. Deputy MacKenzie.
That's right. Yes, we're just going to take a moment to go through it to get you the number, which I believe NSH would be the best responder on that particular item. So I'll defer to CEO Oldfield and Dr. Boutilier to help us find that number.
Okay, MLA LeBlanc, did you want to, while they're getting the data? MLA
Yeah,
LeBlanc?
well, I have a couple more of those. So I'm looking for how many NPs are working in the ERs, how many physician assistants are working in ERs, how many agency nurses are working in ERs, and how much was spent on agency nurses, and how many net new ED or ER physicians are there. So those are some data questions, and then you can let me know when those are ready, and then I can ask another question. Is that okay, Mr. Chair?
Sure.
So I guess the next question is, and maybe this is for the data people too, but you know, this whole action plan on emergency rooms was devised following a response or an increase in ER deaths. And so it seems like knowing about current metrics on ER deaths is a good way to assess the success of the action plan. So how else is the department tracking and measuring the success of the action plan? And is there any other data on hallway medicine? So I know you've mentioned a number of things. You don't need to repeat those things, but is there any other ways that the action plan is being measured? And is there any data on hallway medicine, i.e. how many patients are being treated in the hallways, how often and where?
Perhaps we'll start with Deputy MacKenzie. Deputy MacKenzie.
Thank you, MLA LeBlanc. There's a lot of data points there, so we're going to scurry to find the ones that you spoke about. But your question relates to actions and measurement related to the actions to improve emergency care that was in response to the earlier report. So I'm going to go through some of those actions and the progress in terms of how we've been measuring things. So you will recall that one of the responses with respect to the emergency care plan was to ensure those with the most urgent needs get care quicker. So the response in that regard was having teams led by doctors focus on getting patients out of ambulance and into the emergency department faster. So in terms of the progress on that particular item, float positions are now in play that allow emergency physicians to focus on rapid assessment of patients and efficient flow into and through 7 EDs. And the offload assessment teams, made up of nurses and paramedics, are at 11 EDs, and they move incoming EHS patients into the ED or into an offload zone, freeing up EHS paramedics. So that's one of the measurements and actions we're taking. The other piece is with respect to that plan that you referenced, assigning physician assistants and nurse practitioners, and I know you've asked for the numbers, to provide care in emergency departments. And flipping through our materials, we can see that LPNs, NPs, and physician assistants have been added at Nova Scotia Health ED sites to create a more multidisciplinary approach to ED care. So we, in 21 EDs currently employ 119 LPNs. 8 EDs currently employ 10 nurse practitioners. 2 emergency departments, or EDs, so I'm careful with my acronyms, currently employ 4 physician assistants with a physician assistant training program currently ongoing. The other way that we're trying to achieve that goal of ensuring those with the most urgent care needs get care quicker is to add care providers and patient advocates to support the patients in the waiting rooms. So there are approximately 100 waiting room care providers and patient advocates, and they've been added in 13 Nova Scotia Health and IWK emergency departments, and they provide increased support and comfort measures for patients in EDs. The other piece that's attached to this goal of ensuring those with the most urgent care needs get care quicker is with respect to making virtual care available to more patients with less urgent needs. Virtual Emergency Nova Scotia provides support by linking appropriate patients with emergency physicians and is available at Yarmouth Regional and All Saints Hospital. 3,358 patients have received care through that pathway. Virtual Urgent Nova Scotia connects appropriate ED and urgent treatment center patients to out-of-province physicians. There have been 21,065 visits via this platform to date. In addition, some callers to 811 who would have been previously given direction to go to an ED have been directed to Virtual Urgent Nova Scotia, avoiding ED visits in most of those cases.
Order. I think MLA LeBlanc has another question. Or MLA LeBlanc.
Thank you. I just wanted to follow up on those numbers of the staffing positions. So when you just listed the eight EDs have 10 NPs, 2 EDs have 4 PAs. Those are the numbers that I was requesting earlier, or are those?
I believe they are.
Okay, great. So
Deputy MacKenzie.
I can confirm they are.
Okay. Just want to then say, so what is the plan then for instance, like how many, first of all, quick answer, how many EDs are there in the province?
Deputy MacKenzie.
So for a total number, I'm going to defer to the experts and Dr. Boutilier. I don't want to say the wrong number.
Okay, Dr. Boutilier.
We have 10 regionals, 1 tertiary care, 7 UTCs. We have 11 community.
Okay, that's fine.
Okay, yeah, sure. MLA LeBlanc.
So then, like, basically, for only 2 EDs in the province to have 4 physician assistants, I'm wondering, what is the plan? Like, is the plan to add more? Is the plan to add more NPs? When can we see fully staffed, NPs across the spectrum of ERs, EDs? And then I'm assuming the training program will help with the PAs, but what is the goal for that, for PAs and NPs in particular?
Yeah, Ms. Oldfield.
Thank you. Excuse me. I think the goal is to, we need to train more NPs. So as we've indicated to the committee before, we've increased the number of seats and looking for ways to increase the pathways for RNs to become NPs. I mean, NPs have become a very valuable resource in the province. And from my perspective, the more we can possibly recruit, retain, and grow and educate, the better. It's the same with PAs. The program was started. The first class will graduate, I think, at the end of 2025. That is 26 PAs. They're also highly sought after, not just in our ERs, but there would be many collaborative clinics who would also want to have a physician assistant, as well as a health home and many of the other clinics in our province. So again, if I could triple those numbers, I'd be happy to.
MLA LeBlanc.
That's great. Thank you. So I'm sure everyone is aware of the awful story out of Truro about the child whose misdiagnosis, including at an emergency department, was found to have the bacterial brain infection and then had emergency surgery at the IWK. So my first question is, how does something like that happen? I'm not, obviously I'm not a physician, but there was 2 physicians that saw the child, and then then they were brought into the IWK. How does something like that happen, and how frequent are those near misses, and how are they tracked?
Dr. Boutilier?
Thanks for the question. So anytime we have something that we look into, we initiate processes through our quality and safety patient department, where we invoke a full investigation and a review called a quality review, where it looks at the instances of, was there any kind of system things we can improve on? What were the factors that contributed to the situation? And a lot of that is we assign people to look into that from other places or from other hospitals, things like that. And we, have a full scale review
MLA LeBlanc.
And so, how many of those types of reviews, the serious patient safety incidents, have there been in the last year, and how many reports come out from those reviews?
Dr. Boutilier.
We'd have to get that number for you.
Okay, MLA LeBlanc.
Thanks. And so I guess the next question about those is, like, do the reports contain recommendations? Like, are they specific to the actual, like, to the incident itself, or are they more broad recommendations? What accountability measures are put in place to ensure that the reports lead to actual changes and improvements?
Dr. Boutilier.
So the recommendations can be both. We can. It just depends on the quality of the review, like in terms of where it leads us. So we fill it out. We go through it. We list the recommendations. We put timeframes around all of them to implement.
MLA LeBlanc.
Thank you. So I guess my next question is for the Deputy Minister. Although the Health Authority is conducting its own internal quality review about that incident, there have been calls for a more comprehensive systems-wide review of factors that led to that particular incident. I'm wondering if that's something the department is considering.
Deputy MacKenzie.
Thank you for the question. The quality review and the process that's been investigated is a legislated, publicly known process that is dedicated to a fulsome, complete, in-depth review inside the facility where the event happened. And we have a lot of confidence in those processes. So we would be supporting that and wanting to ensure that we are as supportive of our NSH colleagues with respect to providing whatever that process needs, but there wouldn't be a parallel process inside Department of Health and Wellness.
Okay, MLA LeBlanc.
Thank you. So for the department and also NSH, part of the 14-point plan included adding a second life flight aircraft for patient transfers, but NSGEU has recently said that life flight service at the IWK was out of service for about 50 hours between January and March this year because of a shortage of respiratory therapists. Can anyone speak to the staffing capabilities in the province right now to operate 2 life flight aircrafts?
Yeah, well, Mr. Fraser.
Thanks for the question. So you are correct. There were challenges earlier with the respiratory technicians. I think the IWK is working really hard to be able to fill that gap for us. So we're comfortable that we're able to provide service not only to Nova Scotians, but in our sister provinces. We do provide critical care service support to those provinces as well. So our air program is exceptionally busy, and our staffing is probably well on the way to being as solid as it possibly can be.
Okay. MLA LeBlanc.
So are you confident that we can operate 2 aircrafts right now?
Mr. Fraser.
So what's important to note is that we have 2 helicopters. One is operational, the other is used so if we have any issues with maintenance, that we don't have any delays, that we can get another aircraft in the air. We don't fly 2 helicopters at the same time. So the teams, which are comprised of adult teams that are based at the airport, PEDS, NEO, and maternity teams are based at the IWK. So we mobilize those teams. But beyond the aircraft, we also have a ground critical care unit as well. But it's important to note that 2 helicopters do not fly at the same time.
MLA LeBlanc.
Okay. Good to know. But so then why was adding a second helicopter to part of the 14-point plan? Or am I misinterpreting the plan?
Mr. Fraser.
Potentially. The reality is that in order to reduce downtime, there's a lot of downtime that occurs after an aircraft is as busy as ours is, so we can reduce the mechanical downtime and have an aircraft ready to go, so that we minimize delays.
MLA LeBlanc.
Thank you. So, sorry, I'm going to skip over that question because I think it was answered. Can EMCI provide an update on whether EMCI has developed a staffing strategy, or what stage are you at with developing that?
Mr. Crossman.
Yeah, thank you for the question, MLA LeBlanc. We have developed a comprehensive strategy plan. We've worked with the department and are actually reviewing it again this week. We have a 5-year forecast for projections on what we're going to need for numbers, and we're holding ourselves accountable every single year to recruit and retain. As I said, we've made a lot of progress around staffing. I don't want to take our foot off the gas. That's going to be something that's going to be paramount to our success over the number of years. But we're feeling really good about the changes that have been made, and we're hearing, and when I'm out with the frontline staff, I'm hearing a lot of positive feedback that things have changed and things feel a little different. And I think that's going to be really important for us to retain staff. So it's one thing to get people through the door, but it's another to better support them and make sure that they're given all the things that they need to be successful. And that's going to be our focus as well, as supporting that workforce. So,
MLA LeBlanc.
Thank you. So in July, the NSH agreed that ER deaths are partially due to sicker patients stemming from family physician shortage, and you did most of you referenced the some of the steps being taken to keep people out of the ERs. Can you tell us how many Nova Scotians have been attached from the Need of Family Practice Registry to new collaborative family practices that opened in 2023 in Masstown, Amherst, and Eastern Passage?
Dr. Boutilier. Yeah.
Sorry,
Okay.
apologies.
All good.
We would have to get those numbers for you.
Okay. MLA LeBlanc with about 3.5 minutes.
Okay, today, like now, or like follow up after the meeting?
Dr. Boutilier.
Okay, that's fine.
MLA.
I think it would have to be follow-up. We need to make sure it's right. I don't want to be giving any misinformation.
MLA LeBlanc.
Great. Can you tell me if all of the new collaborative family practices have family physicians working full-time, or are some still being staffed totally by nurses and nurse practitioners?
Dr. Boutilier.
Yes, we have, you may be referring to our primary care clinics that have NPs and nurses only, but our collaborative practice clinics all have physicians as part of them. Depending on where you are in the province, some of the collaborative physicians do other things. They work in emergency rooms, they work in the hospitals, so FTE varies from, clinic to clinic.
MLA LeBlanc.
Yeah, specifically, I'm talking about the one at Masstown, Amherst, and Eastern Passage. And I'm asking for a friend because the word on the street is that there's going to be one opening in Dartmouth North too. So I'm particularly interested in wanting to know exactly how it will be staffed. So some are run by nurses. In the release for the Masstown clinic, it was stated that a part-time doctor would join the clinic in January 2024. Did that happen?
Dr. Boutilier.
I would have to confirm if that happened at that exact time.
Okay. MLA LeBlanc.
Yeah, thank you. Just making sure that the clerk is getting these questions down to follow up with. Did the family physicians at the new clinics transfer their roster from one location to another? Meaning, if they sort of had their own practice and then they came under the umbrella of Nova Scotia Health, did they transfer their patients, or are they new doctors, or starting new practices, onboarding an appropriate number of new patients for a family physician? Yeah.
Okay, Dr. Boutilier.
So we have, just to put it in context, we have almost 100 clinics. So, yeah. But in general, there's two ways. Sometimes we do what we call stabilize. We stabilize to prevent an attachment. So when a new physician comes in, a new doctor may be slowing down. An older physician may be slowing down. They may be sharing part of their resources to start. The person may also take people off the list. It really depends if they inherit a full list or not. But we do that to stabilize the practice and keep them there. Sometimes people are going to newer clinics and starting with someone's roster at a new clinic, because some of the newer physicians that are coming on, they want to work in a collaborative setting with a variety Society of Healthcare Providers. So they would actually maybe replace a retired physician who is in a solo fee-for-service practice, and sometimes those getting closer to retired physicians will actually join us in the new setting as well.
Emily LeBlanc.
Totally get that. I guess this is why I think it's really important that we know exactly where we are with the need of family practice wait list. And this is something that we've been talking about. But if there's 160,000 people on the list and we're adding doctors and adding nurse practitioners and adding clinics, then it just feels like we're doing this game of moving, I don't know what the appropriate video game reference would be, but it feels like we're moving people around.
Order. That concludes my apologies. Time for the NDP colleagues. I'll pass it on to we'll start with MLA Taggart for their 20 minutes.
Thank you, Chair. Well, I can answer the questions on the Primary Care Collaborative Care Center in Masstown, and it is awesome. Great. And I can tell you that for sure. I've been very fortunate, and I just have to say I love nurse practitioners because they do a wonderful job in those clinics. Anyway, so I just had to say that. I feel very fortunate to have that clinic in my constituency. So I want to thank you folks for being here and today to discuss these very important issues. We understand just how important it is to address the challenges of emergency care across the province, and really this is not a partisan issue. It affects every community in a multitude of ways, and certainly there are places in a province where the impact of these programs are happening at different speeds. With that being said, this issue did not happen overnight, and there are no simple solutions. So I believe that these new initiatives will have a positive impact on the delivery of emergency care, both in the immediate future and in the years to come. I think that's very important. And I would encourage every Nova Scotian that may hear today's discussion to consider the good work that is taking place and see it as a positive step forward in a much larger process. So my first question here is really, and a lot of this has already been stated, but I think it's a really important piece. We've made great progress in acting on what was outlined in the Emergency Department Improvement Plan. We have brought in patient advocates, waiting room care providers, flow and offload teams, and virtual care in emergency departments. And could you please ask, and you please talk about these actions and what it has meant to the patient experience?
Ms. Oldfield.
Thank you. We do constant evaluations in many aspects of the system. We're able to talk about metrics and data because we do a lot of measuring. We, and one of the areas would be in the waiting room of an emergency department. So let's just take the patient advocate. And I'm thinking in particular of evaluations at Dartmouth General, because actually Dartmouth General was an early adopter. Before it was even a thing across the province, Dartmouth General had such a role. And the level of comfort, excuse me, the level of comfort and just knowing that there's somebody there looking out for you gives a patient a great deal of confidence. So that's one. But you can extrapolate that across all of the different teams that we've talked about here today. And I think that, what I hope is coming across is that no more are we operating in silos. This is a team game. This is a team game. It starts when a person makes a phone call to 911. And what we've managed to do extremely well over the past year and a bit has been to improve that line of communication between EHS and NSH, no matter where in the province, so that, we just are talking all of the time and going, what about this, what about that? And that also has given not just patients, but our staff as well, just such a higher level of confidence that when the call is made, it's going to get answered. And so I think that what we're trying to do as a team is to create that safety net, make it as strong as possible, make the lines of communication as strong as possible, and that ultimately flows right through to the patient who hopefully, has a much better experience, notwithstanding they are in an emergency room for a reason, which is highly likely not. It's, you know, we want to treat them well, but they're there because they have a health concern.
MLA Taggart.
Thank you. Thank you. So sort of on the, I guess the same theme, you know, it's been like 2 years since the Care Coordination Center opened. It's, you know, it's really an innovative initiative. And could you talk about the difference it has made and what are the plans going forward? And I think that kind of ties into the ER thing there, but, or emergency department. Thanks.
Ms. Oldfield? Ms. Oldfield, yeah.
Thank you. You'd have to talk to the frontline staff who look at that information coming out on the C3 screen every day. But when I've gone into the C3 ops room and you talk to the frontline staff who used to track many of these metrics with their you know, notebook and their pen and making phone calls, what about this, what about this, what about this? And it's impossible with the phone or running to try to find somebody to seek information about a particular patient and their status. It's impossible to track all metrics. You know, does the bed need to be changed? Do they need blood work, etc. So our technology has greatly improved our visibility, not just in Halifax, and that's, I think, the point that needs to be emphasized, but we are able to, we have screens across the province that allows us to have visibility as to bed and bed capacity, no matter where we are in the province. The next step, so this is work that's not complete. I can see this being 2 to 3, it's almost like an evergreen project because you're never done. However, you know, the next parts of it are to continue to spread throughout the province to make sure that the visibility is complete, but also there will be different aspects of the information that we can glean that can be used in different ways. So the C3 team is very, you know, they're on all of the metrics, determining how we best spread them, how people are best able to see them, take advantage of them, and then use them to improve patient care. So it's been an excellent tool. I think it will only continue to increase our ability to improve health care for Nova Scotians.
MLA McLeod.
Thank you. Good morning. I'm not sure exactly who to point the question to, so I'll direct it to the entire board. I'm here on behalf of the folks of Pictou West. So right off the bat, I will ask, in terms of emergency care, what improvements have been made or will be made in my home community of Pictou County?
Ms. Oldfield.
I just wanted to share with MLA McLeod that luckily for him, Dr. Boutilier is from Pictou County, and she will be happy to share the good things that are going on at the Aberdeen.
Dr. Boutilier.
So the Aberdeen is one of our stars in the triage and the offload. They routinely are between 30 and 60 minutes, and most closer to 30 all the time. And they have a really good, an unbelievable culture with EHS where they work very hard, and we've had many site visits from other folks there to see what the magic is that allows these teams to do that. We have a beautiful, as you know, new emergency room that allows us to see patients in many ways. The other thing we've added recently is we've begun the work on the rapid assessment zone there by adding a nurse practitioner. And we're starting to, you know, the numbers that have been able to go through that part of the emergency room is reducing some of the volumes that would previously been waiting by 30%. We always have, you know, there's a lot of staffing challenges, as people know. The Aberdeen is never, ever closes doors as a regional center, as all our regional centers are always open. I think that I think it's really to all of the emergency rooms, but they're really making good progress. They have the waiting care provider positions filled. They have the patient advocate positions filled, and they continue to try to implement all the different recommendations. We have toolkits that people work on. They've come up with innovative ways to let them know when they're, and this can go for all the teams across the province, looking at ways that they can actually be always aware of what's coming in, what's on the ambulance stretchers, when they're approaching offload times. And also really close eyes on the patients. We'll be, continuing to implement those at the Aberdeen and everywhere.
MLA McLeod.
Thank you. Again, a question for the board. I've heard of virtual care in emergency departments. Knock on wood, I haven't been to an emergency department recently, so I'm not familiar with the virtual care. I was wondering if you could explain how the virtual care in emergency departments affects the patient experience.
Okay, Dr. Boutilier, we'll start there.
Thank you.
Ms. Oldfield.
Thank you. There are really two things that should be explained. One is virtual emergency, and one is virtual urgent. So let's start with the virtual emergency. We have two departments across the province that are currently using this, and this is it's innovative, and it's a Nova Scotia innovation, which was the technology that we're using was created by Dr. Jan Summers, who's an emergency physician in Colchester. And during COVID, she was looking for ways to treat patients and devised this methodology. So how it works is that when a person presents, then if it is acceptable and suitable, then they can be seen virtually. It doesn't work for all cases, of course. So that the individual will have somebody with them, so it could be an RN, it could be another healthcare professional, while the emergency physician is connected virtually. So the patient is seen virtually and treated virtually. And we are currently using that technology in 2 emergency departments, as I said. And, we're, as people are comfortable and we are comfortable, then it's something that we would look at scaling if it makes sense. So that's one. And the second pathway is virtual urgent, which is also very relevant to our ERs. And I'll ask Dr. Boutilier to touch on that one.
Dr. Boutilier.
Yeah, so we've now expanded to, I think, 17 different sites for virtual urgent. So when we can have people that need to see someone sort of in an urgent way, and we may have different levels of staffing and things like that are happening, we can actually connect them virtually, and it's run by a group we've connected with out of province. So the physicians are out of province, so it's allowed us to expand our ability to treat emergency patients. And I believe there's been over 20,000 visits through the virtual urgent path already.
MLA McLeod.
Thank you. I will pass to MLA Sheehy Richard.
MLA Sheehy Richard.
Wanted to get that right.
Thank you, Mr. Chair. I know, longest name in the legislature, so it's a challenging one. How much time is there, Mr. Chair?
You have until 10:24.
Okay, thank you. I just wanted to dive in while I have the opportunity just to talk about and thank you for the incredible work that everyone's doing. It is appreciated, and sometimes it's difficult to see the change, but when you're in the change and living it, steps are being taken. So I just wanted to talk, if we could, and the opportunity, I represent Hants Community Hospital, beautiful little community hospital that happens to be, as I'm told by the teams that I meet with quarterly, that it's the busiest level 3 in the province. So, of course, at times the ED does have to be closed, unfortunately, and can be of concern of the community. But I was just wondering if you can talk about reasons why these closures sometimes happen, what that means for the actual ED, is the door still open, what types of things are there, and maybe just a little bit of insight on some steps that are underway. I hope and understand in the coming months to look at some of that in the community.
Okay, I'll reckon 10:24:30. Sorry, I recognize Dr. Boutilier.
Thank you. Thanks for the question, and thanks for the acknowledgement of the work. We're very proud of our teams and how everybody across the system is digging into these issues, helping us. We do have shortages of different providers, as everyone knows, and it's something that the entire, all of Canada struggles with. And so some of the times when we have to close emergency rooms, it may be due to a shortage of providers, maybe physicians, maybe nurses. It varies. And, we make a really big effort to keep all of them open. And especially when it's really important, the Hants corridor, other ones, during certain times, we really try to focus on that. But our priority has to be in those circumstances at times to pull staff to our regionals or our other community centers. It just depends on where you are and what level of facility we're talking about. Ideally, we would fully staff and have open at all times, and we make really close connections with our EHS partners at those times so that they know where we are open and fully open. So some of the advances we've made with that is really with the urgent treatment centers, and is that we have the urgent treatment centers that are predictable and that people know where to go and get the care. There'll be 7 open now. One just opened in Yarmouth yesterday, I believe. And having that scheduled time when people can seek care is really important. If they need an X-ray, stitches, all those kind of things. The other thing is sometimes when we have closures and we know that the closures will be in the month, we would schedule it, rather than just, announcing an unexpected closure. So we try to avoid unexpected closures above all. Some of the things that we're doing, recruitment, of course. We're all over the world looking for physicians, emergency physicians, and other physicians. We have processes now due to changes in either our own college or the Royal College where we can actually recruit folks that previously wouldn't have been automatically getting a license through a practice ready assessment. We've recently started for the first time in Nova Scotia practice ready assessments of emergency room physicians, which gives us a whole new avenue of ability to recruit. And it's going very well, and we expect to continue to bring in more people for practice-ready assessments to be able to go to our emergency rooms and work.
MLA Sheehy Richard.
Yeah, and I guess I just wanted to talk about some of the implements that was discussed. The virtual urgent care as being a good option for Hants, and I know for a fact that we just recently hired a new RN to start in our ED, and I think that those are all just key pivotal things to know. And the reassurance there that the doors are never locked, that there is care in the community as needed, and we do have a lot of other alternative measures, and it's trying to reset the mindset sometimes in a rural community that I represent. So if Ms. Oldfield wanted to add, I think she does, to some of the advancements that I think are being looked at for the community on a whole to reduce the need to go there in the first place, if you will. Ms. Oldfield?
Ms. Oldfield with about a minute and a half.
Thank you. I think I've said this before at this committee, but if any one of us could wave a magic wand and create teams, whether they are in surgery, whether they are in the ICU, whether they are in the ED, we would. So that doesn't work, but what works is we've created the seats. Yes, that does take time. We're recruiting extensively. It doesn't matter which role, which job, which position. Our job fair as an example, was hugely successful. And I suspect we'll be doing it again. So there's no part of the province that we don't have our eye on. And there's no part of the province that we would say, oh, well, you know, that doesn't matter, because that is not true. It is a huge, monumental task. You know, you acknowledge the teams. I do too, every day. I mean, folks are really digging in, and they are working very, very hard. And that's why it's moving, because they're putting the effort to the wheel, and it's moving. So, you know, there's no stone unturned here. In fact, as I've also said before, like, the good ideas are welcome.
Order. That concludes time for the PC colleagues. Our second round of questioning will be approximately 5 minutes each. I'll start with the Liberal colleagues. MLA Regan.
Thank you, Mr. Chair. I hope there's no approximation. It's exactly 5 minutes each. Is that right? Okay, thanks. So thank you very much for coming today. I know that folks are very busy, and we do appreciate the work that you have been doing. I'm wondering if someone can indicate for me, I noticed that inpatient surgeries, when we look at the total number of surgeries for the province, they are down pretty much every week compared to 2019. And we were told that our operating rooms would be open 24/7. This is the government's own data that I'm looking at here. 24/7. Have we achieved 24/7 operating rooms in this province at this time? For whoever can answer.
Ms. Oldfield.
Simple answer is no, we have not.
MLA Regan.
What about surgeries at the Halifax Infirmary? I know that there was a story out some time ago saying that the reason they were down is because they were doing more of the more serious ones. But I've spent more time in hospitals this past year than I've ever in my entire life, not because of my health or anything like that, but because of a family member's health. And I would say the takeaway that I have is don't get sick on a Friday. Don't get seriously ill on a Friday, because you're going to sit there and wait for someone to perform surgery. Can you give me any indication as to whether we have operating rooms fully operational on weekends at the Halifax Infirmary?
Dr. Boutilier, will you start?
Sure. First of all, I want to go back. We've actually had a 25% reduction in our surgical wait list. And we operate in our operating rooms 7 days a week, elective versus, planned surgeries. But always emergency surgeries are available.
MLA Regan.
Thank you. I understand that there has been a reduction in the wait list, but according to the government's own public relations people, the number of inpatient surgeries are down. So why is that? Why is that happening? It's like, if you look at your own data, you can see week after week the numbers are down from 2019. That's inpatient surgeries. And I will tell you, because I only have a certain amount of time, and I'm not going to listen to a regurgitation of stuff that we've already heard, so I'm going to say my piece. And that is, when listening to folks here who I know are working very hard, it's a very different reality when we talk to our constituents. They are upset. They have a very different experience. Diabetic patients left to sit in rooms for hours and hours, no meals. I was in emergency repeatedly this past year with an adult child who was very ill. At no time did anyone ever identify themselves as a waiting room care provider or patient advocate. My child was extremely ill. The surgical resident said, quite frankly, if she had been older or in less good shape, she would have died from what she had. And she would sit there for hours. And you may say, oh, the time to triage, but I'll tell you, triage is just the first part. You can get triaged in minutes. And then you sit there for hours and hours in agony. And then you wait for 3.5 days to have a stent put in. A simple operation, but because it's over the weekend, you're sitting there. And this is the kind of thing that still continues to happen in this province. Don't get ill. Don't get really sick in Halifax on a Friday, is all I'm telling you. These are good improvements, having patient advocates. But if they don't actually go around the room and check on people, it's no good. I've never felt so helpless in my life. Watching my child yellow because they're...
Order. That concludes time for the Liberal colleagues. I recognize the NDP, MLA Lachance.
Great, thank you. And I only have a short time, so I'm not gonna. I'm just gonna have some rapid fire questions, hopefully. So one question I have is, you know, I certainly understand the interconnectedness of the healthcare system and the need for everything to be working well together. So thinking about primary care attachment, you know, Halifax, Citadel, Sable Island has one of the last time we had publicly available figures, had one of the largest amount of unattached patients in the province. So I think we were at 23% in June. And I would say too that the number of people on the doorstep that I talked to who just haven't even bothered to get on the wait list because they're like, when will it ever happen? People have not bothered to sort of update the wait list. Like, people are just skeptical that they'll ever have a primary care provider. And so one of the questions I asked the Minister of Health in that time in a written letter, but I don't think I've received a response, is, so if I have a riding with 23% of folks who are unattached, what percentage, how do we know people are also receiving primary care? So from Halifax, Citadel, Sable Island, like, how many folks are having virtual care appointments? How many folks are at primary health clinics? Like, do we have that information? I'm willing to consider that there are various ways of folks to access health care, but I want to know that almost a quarter of the folks in my riding who don't have a primary care provider, those of whom have registered, also have access in different ways to primary care.
Dr. Boutilier.
Yes, we know that over, like, you know, the numbers that of people accessing different ways, and watching that carefully. I could never say it off the top of my head, like, in your riding type of thing or anything. It is really important. Like, one of the things about the registry that people don't understand.
I think she's signaling you should have another question to follow up to that. MLA Lachance.
I do apologize. I only have a few minutes. I have asked the minister for that information, and I would appreciate the information specifically for my riding would be excellent, and you know, and potentially, you know, for the whole central zone would also be helpful because you know, I think that the Action for Health public reporting includes numbers of appointments at primary care clinics for virtual care for western, northern, eastern zones, but not central. So it's really essential that we know how folks in the central zone are able to access care. I wanted to ask some questions along the lines, in fact, of what MLA Regan was talking about. So, you know, I think patient advocates, the physician flow advisors, you know, rapid assessment centers, these all sound like excellent innovations. But what I'm wondering is, particularly when I think about like the physician flow advisors, you know, nurse practitioners, others, are they working, like, when are they working? So, you know, we have information, we know when ERs are at their busiest, it tends to be evenings and weekends. Is that when the 7 patient flow advisors are working in the ERs?
Dr. Boutilier.
We try to fill as many shifts as we can every day of the week.
MLA Lachance. So typically, maybe we get very specific. So is there a physician flow advisor at the ER, at the QE2, and what hours do they work?
Dr. Boutilier. It's okay.
It depends on the facility. It depends on the way they organize their shifts. It depends on how many shifts are filled.
MLA Lachance.
In your best estimation, or as a policy perhaps, are those shifts assigned based on demand at the ERs?
Dr. Boutilier.
We always are, and the Department of Health could speak to that, on looking at the flow and the amount of physicians and how many physicians we support for any one shift. We would try with the float physician to have it at the most appropriate times, and it's different for every facility. When they actually decide when they're going to have it, one facility may have different shifts that overlap, and it's better to have it at a different time.
MLA Lachance.
I mean, if that specific information is available, I'd be grateful to receive it. Another question. So in terms of collaborative healthcare clinics, the sort of theory around physician health homes or collaborative care
Order.
clinics.
That concludes time for the NDP. I pass it on to the PC colleagues. MLA Taggart.
Thank you, Chair. My question, I think, is I'm not for Mr. Fraser or Mr. Crossman, but EHS has been innovative in complementing its paramedics through introducing emergency medical responders and investing in medical first responders such as firefighters. And in a rural area, they're pretty darn important to our communities. Could you please outline how each of these roles has helped to expand the EHS's capabilities? Mr. Fraser?
Yeah, Mr. Fraser.
Thank you for the question. MLA Taggart, I think the guiding principles that we began to follow a few years ago. We know that not all patients need a paramedic, not all the callers need an ambulance, and not every patient needs a hospital. And we continue to transform the system. You asked about emergency medical responders. That is the new profession that we've created over the last 8 months to help augment the EHS system. We've also spent a great deal of time working with our partners across the medical first response community, or the firefighters, which you've indicated, which is an integral part in our link of care. So as discussed earlier, care begins when you access 911. Across many of our rural communities, we have medical first responders there. Spent a lot of time in that space over the last number of years, not only acknowledging the downstream effect of ambulance offload challenges that have happened and what their experience has been, but really tried to refocus on what we're asking these folks to do within community. They make a difference. I worked as a paramedic myself many years ago, and nothing was more comforting arriving on a scene and running into one of these folks. That is a part of our program. We focused on training, enhancing their training, enhancing their equipment, and we've got a roadmap over the next number of years of enhancements we'll continue to make and invest in these important resources across our system.
MLA Taggart.
Time?
You have till 10:39:30.
Great. Well, I just want to follow up on that. Those what I call medical emergency first responders, rural firefighters, are godsend in our communities, and some of them are extremely well trained, committed volunteers, and I'm thrilled to see that you folks are, if I understand it right, see that value. We're working with them, and I think maybe training them up more in certain places. So I really appreciate that. No matter what new initiatives are brought in, we need staffing. There's no question about that. And I know you folks had great success with the paramedics from Australia, 30, I believe, and I believe we've made advances in growing ED staffing members. Is there anybody here would somebody like to talk about the progress being made in recruiting staff that we need for emergency departments and emergency health services? Is anybody that hasn't been said to date, already? But I think it's one of our biggest challenges, right? Staffing. We
start with Mr. Fraser.
Thanks for the question.
Mr. Fraser. Yep.
Thank you for the question. I can start, and I'll probably hand this off to Mr. Crossman. Going back to what I said a few moments ago, the diversification is important. Not all patients need a paramedic. And so what we've done and spent time in this space over the last 2 years is looking at how do we split our system up and to make sure that we've got the right provider responding to the right patient at the right time. That included the development of transfer operators, recognizing that almost half of our services volume is moving patients in a facility, work that paramedics necessarily don't need to do. we're below 20% of the time now. Paramedics are moving patients in between facilities, and we use this number today. You've heard about the impact of our aircraft on moving transfer patients, which creates capacity in the community. The fantastic work that the health authorities undertaken to free up capacity in the community. This is all about increasing the capacity and making sure we've got the right provider at the right patient at the right time. So that's really what our focus has been. As far as recruitment, I'm going to turn it over in retention to Mr. Crossman.
Mr. Crossman, you have 25 seconds.
Great. As I kind of mentioned earlier, we've had great success in recruiting. You mentioned the Australia mission. We're actually doing another one right now, which has yielded great success. But locally, we're really focused on getting Nova Scotians into the programs, and the EMR is a great step for people to try it, see the profession, and then continue through their career. So we're really confident over the next number of years we're going to close the gap.
Perfect timing. Order. This concludes our questioning. Thank the witnesses. I'd invite them for some brief closing remarks if we have any, and I'll start with Deputy MacKenzie.
Thank you, Mr. Chair, and thank you to the committee for your questions and the exchange here today. And I didn't want to close without addressing MLA Regan's remarks. They're compelling. And when I opened my remarks, I talked about putting patients at the center of everything. And any negative experience is really hard. And we regret and are sorry for those types of experiences and are committed to and open to talking to you about more about it so we can understand the experience and learn from it. And patient experiences are the most important input we have, and we are collectively doing more. We are seeing improvements in flow, response times, and ambulance hours. But we do need to keep hearing from the patient. And appearances like today help us with that. And the system can only change when the system listens to all of its parts. So thank you for this today. Thank you for the questions. And we look forward to talking more about this as time goes on. Thank you.
Thank you. Yeah, Ms. Oldfield.
Thank you, Chair. As the deputy says, this team and many, many more are completely committed to transforming healthcare in this province, from shortening the wait times in the emergency departments to ensuring that Nova Scotians are aware of all their care options. These are very important things. I do have one little tiny point that I would like to share because I think it's important and I don't know how I missed it. But, when we talk about patient advocates and waiting room providers, there is one thing that we have trialed that's, I think, going to be really good going forward, and that is it's a wearable. It's been trialed at the Dartmouth General, and it sends vital signs direct to the triage desk and to the charge nurse. And so this is yet another tool that gives our patients comfort that somebody's there and watching for them. So we, I think, are going forward to scale that across the province, so that will be coming soon.
Thank you, Ms. Oldfield. Okay, I'm seeing no other hands here. You're free to carry on your day. We have a significant amount of committee business here, so I'm going to just hop right into this. I think probably the most pressing thing is for topics, to have topics in the upcoming meetings. So perhaps we'll move into our agenda, our record of decision, and I recognize MLA McDonald.
Thank you, Mr. Chair. As reviewing the record of decision as presented, as opposed to reading all this out, I'm just going to say that I move to accept the record of decision with the exception of the items of the one for population growth, the topic of government measures addressing affordability, the item of virtual care contracts, and Nova Scotia Loyal Program.
Is there any debate? Yeah.
Have a second to digest what you just said?
Yeah, sorry, MLA LeBlanc.
Sorry, can we just have a 2-minute recess to digest what the member has suggested?
Two
Two
minutes?
minutes.
Sure.
Yeah, thanks.
2-minute recess.
Thank
We'll be
you.
back at 10:45. We're now in recess.
Kelly.
Order. The committee resumes. I recognize MLA LaChance.
I think I just want to clarify why the government is suggesting to remove the topic of virtual care contracts.
MLA McDonald.
Well, I would just submit we had 13, which is a huge that went through, and I just went through ones that I thought could be deferred or they've been discussed at other ones. So I just leave it at that. Thank you.
MLA LaChance.
You know, I think we can all agree that healthcare is critical. This is what this government ran on. We just heard from, you know, a wealth of information, but really also took home the message that our healthcare system, of course, is interconnected and complex. So I think that we should retain virtual care contracts in this list.
MLA Clark.
Thank you, Mr. Chair. Just a quick point. I take MLA LaChance's point. I understand that the die is cast here more or less, but I also just wanted to make the point that I think the other topic that has been removed that I think is important is government measures addressing affordability, obviously between healthcare and cost of living. We all agree those are the two major issues. I would love to see those two topics retained on the list, but I will leave it to my colleagues to make that choice on the vote.
Seeing no further discussion, are we ready for the question? All those in favor of the motion, please signify by saying aye. Aye. Contrary minded, nay. The motion carries. Okay, we have topics. Okay, we'll hop back down to just from the top of our agenda here. We'll start with committee business. Then we have correspondence. So I'm not going to read all the correspondence today, but I'm assuming everyone has had an opportunity to read these. The first correspondence piece was the Office of the Auditor General 2023-24 Performance Report, 2024-25 Business Plan, and 2023-24 Audited Financial Statements. Do we have any discussion on these topics? Seeing none, moving into the Department of Education and Early Childhood Development, we had information requested from the June 19th meeting. Do we have discussion on that item? Moving along. Nova Scotia Health, information requested from the May 22nd meeting. Is there discussion on that piece of correspondence? Seeing none. We have the CAAF workshop. The CAAF has been tentatively scheduled to provide the committee with a workshop on the 18th day of September and possibly the 19th. Given that the legislature has resumed, is the committee still wanting to proceed with this workshop, and would they want to take it over 1 to 2 days? MLA LeBlanc.
I think it's pretty much impossible to do it while the House is sitting, but I do think it's really important, and it's the, you know, we those of us who have taken them before know that they're very helpful. So I would suggest continuing, keeping with the 2-day version of the workshop, but seeing if CAF can move it to maybe later in October, when we presumably will not be sitting. However, we may be in an election, but who knows?
How does the committee feel about this suggestion? Do we have anybody else? Yeah. So I guess MLA McDonald.
Just to be clear, we're confirming about moving to October, not the point that we want to have an election. I'm just making sure.
Yes.
Make sure on the record I don't come back and somebody says MLA McDonald won an election in the fall. So
we're confirming to move this until October. Okay, give me 1 second here. Just so the committee's aware then, if we do defer this until October, seeing how we just passed the record decision today, and I think it'd be a lot on the clerk to try to schedule witnesses over the next 7 days to get into a meeting here. We'll have nothing scheduled for next week, just so everybody's clear. Yeah, okay. Seeing lots of nods, unanimous. Okay, let's move on. What are we at here? Okay. We have the endorsement of the Auditor General recommendations regarding the 2024 report of the Auditor General. That was on, if you remember, preventing and addressing violence in Nova Scotia public schools. And the committee has a practice of endorsing Auditor General recommendations that have been accepted. So I would ask that somebody put a motion forward. MLA McDonald. MLA McDonald.
Thank you, Mr. Chair. I move that the recommendations approved by the department are moved.
There's an actual motion.
Oh, is there? I went look and I couldn't find it. You got it? Oh, look.
MLA McDonald.
Thank you, Mr. Chair and my colleague. I move that the public accounts formally accept and endorse the recommendations contained in the 2024 report of the Auditor General preventing and addressing violence in the Nova Scotia public schools that have been accepted by the audited departments or agencies, and ask that those departments and agencies commit to and take responsibility for full and timely implementation of the recommendations accepted by those departments and agencies.
Short one. Seeing no hands, we ready for the question? All those in favor of the motion, please signify by saying aye. Aye. Contrary minded, nay. That motion carries. Okay, are we down to the last one? We did have a, MLA Clark had a motion. It was left on the floor for the 19th day of June. The motion that was left on the floor reads as follows: that the committee request that the Department of Education and Early Childhood Development work to implement the recommendations for this report before the next school year, including providing clear directive to teachers regarding discipline in the classroom, committing to hiring more teacher assistants and school support staff to reduce pressure on teachers in our schools, allowing teachers that have more monitoring time, introducing a detailed plan to reduce overcrowding in our schools. And I request that the committee hold a meeting on this topic in September, and the Department of Education and Early Childhood Development be called back as witness to update the committee on progress in implementing these changes. And just before we get into discussion on this motion, this would have came late. I think it was an oversight perhaps by the clerk. Do we want to deal with this motion now? Or okay, MLA LeBlanc.
Well, thank you. I'll just say, I mean, part of it is probably null and void, but the part about calling back the department for a sooner meeting than what would normally be the case, I think is important. So perhaps we can flag that for our next agenda setting. Perhaps it could be at the top of the next round of agenda items.
So I think what we'd have to do is maybe have unanimous consent to retract the motion, or we could amend it into, hang on. So motion to defer, motion to table? Yeah, MLA Clark.
Thank you, Mr. Chair. I have no issue with that in terms of moving to defer, table, whatever the correct terminology would be. I can't recall this off the top of my head, but I believe the Auditor General's office was talking about maybe updating on that report faster than normal. So I think that's something that, you know, obviously I would like to see, and I hope we would all like to see. So to Emily LeBlanc's point, I think it's just one that perhaps we can, you know, put extra emphasis on to make sure that we get the update on it as soon as possible, which I believe was the intention of the AG's office on that report in particular. So that's all.
Emily McDonald, did I see your hand? Emily McDonald.
Yeah, Mr. Chair, and it's just the point that the only bad part of deferring and table, it's going to sit on there. So if I'd rather vote it down and agree unanimously that, you know, because the Auditor General did say they will do it quicker. It's happened for others, for the Fire Marshal's office. They're doing that quicker. They're not doing the 2 years. If they're in confirmation that it is going to be fast-tracked, I'd prefer to vote it down. Rather, it would sit on the thing tabled as to forever. So that's just a process for me.
I think it'd be more comfortable with unanimous just to remove it. Can I reach unanimous consent to remove this? Yeah, seeing lots of nods there. Okay, that is removed. All right. Wow, I did not expect that. Emily McDonald.
Since we have the rep for the auditors, did we want to get confirmation for the member that it is being fast-tracked, or at least we have that? Do you know what I mean? Since the member's here, let's get confirmation for him.
Would you like to come up to the... Office of the Auditor General, Mr. Harding.
Hi. I do apologize. I don't have the answer off the top of my head as to whether that's on our list. I would have to go back to the office and confirm that we are following up on that one earlier. I just can't recall off the top of my head.
Okay. Yeah. Perfect. Okay. Our next committee meeting will be communicated through us through the clerk. And once we have that information, we will meet again. And I'd just like to say we had an awful lot of committee business here today, members, and we got through it. So thank you. Thank you, everybody. Have a great day. We're now adjourned.
You finished 10 minutes early.